Good afternoon and good evening for those attending today's forum from abroad. My name is Russ Ganim, and I am the Dean of International Programs at the University of Iowa. It is my great pleasure to welcome you to our Global Alumni Spotlight Series today, featuring Dr. Alfredo Vergara, CDC Country Director and Division of Global HIV and TB Program Director for Mozambique. Today's talk marks the second in our series, the goal of which is to showcase the work of preeminent international UI alumni around the globe. We thank the College of Public Health for suggesting that Dr. Vergara be part of the Global Alumni Spotlight Series, as well as the Communications and Constituent Relations team in international programs for their usual superb work in putting together today's program. We note that questions may be submitted through the Q&A function of the webinar and will be curated and posed near the end of the interview. Please allow me to give a brief bio of Dr. Vergara before starting what promises to be a fascinating conversation. Dr. Alfredo Vergara is an epidemiologist with 28 years of experience in public health program implementation. He began his service at CDC as an EIS officer in 1993 and has subsequently worked in areas of environmental health, global health and migration, as well as HIV/AIDS. In 2000, Alfredo opened and established CDC's first office in Mozambique, focusing on implementation of the President's Emergency Plan for AIDS Relief, also known as PEPFAR, where he served as the CDC Country Director and Public Health Attaché at the U.S. Embassy in Mozambique. Alfredo also served as Associate Director for Program Development at Vanderbilt's Institute for Global Health, VIGH, leading the development of multidisciplinary global health programs and teaching public health. During his tenure at VIGH, he established multidisciplinary collaborations across Vanderbilt School of Medicine, Education, and Business, linking various departments and institutes with the aim of building applied programs addressing health and development. He taught environmental health in the MPH program and helped develop the global health track of the MPH program as well. In 2013, Alfredo returned to Mozambique, serving as branch chief, tasked with strengthening the public health system at the CDC Mozambique. In 2016, he was named director for CDC Mozambique a second time, overseeing a budget of $180 million and a staff of 90 plus epidemiologists, clinicians, and other scientists implementing programs to achieve epidemic control of HIV in Mozambique. Dr. Vergara was awarded a BS in biomedical engineering by the University of Iowa, an MS in environmental science, and a PhD in epidemiology by the University of Iowa's Department of Preventive Medicine. Alfredo, thank you for joining us on the Global Health Alumni Series, and welcome.
Thank you very much. It's a total pleasure to be here, and I only wish that I could be there in person and visit Iowa after not having come back in the last 10 years.
Well, we will try to make that happen sometime soon. It's great to see you, albeit virtually. We hope you and your family are well, and that things are up and running in Mozambique, and that you remain healthy. Let's go ahead and just start with the first question. Just tell us a little bit about your background, sort of where you grew up and how you came to Iowa. What's the story behind that?
Well, I am originally from Venezuela, even though I'm the only Venezuelan in my family, because my family comes from Chile. And I left Venezuela when I was 18 with a scholarship from the Venezuelan government. And I wanted to study medicine, but they would not give me a scholarship for medicine. And so I chose biomedical engineering, which was the closest thing. And Iowa was essentially chosen by the Scholarship Foundation so that I would not be around a lot of Latin Americans and therefore not learn English.
I see what you're saying. And wasn't it true that you came to Coe College first before the University of Iowa? Yeah.
I came to Coe College first. That's the school that the scholarship had an agreement with. And so I was there for about 8 months, and then I transferred to the University of Iowa.
Right. And you stayed at Iowa for a long time, and we're certainly glad that you made that decision.
I did. I consider when people ask me where are you from, I tell them I'm from the Midwest, and see if it passes.
Very good, very good. Well, you certainly are a Midwesterner in our eyes. So Alfredo, tell us a little bit about what drew you to the field of preventive medicine. Was there anything in your background that attracted you to that field, or it was just something where you said, well, I have an aptitude for this, I want to help people, and maybe I'll make that my life's work?
Well, I was interested in health since I was, probably a teenager. And I did a little bit of public health work when I was in Venezuela in the poor neighborhoods around Caracas. I was going to a Catholic school, and the priests there had a very strong social action program, and so we did things like looking at cholera outbreaks in the community, building latrines and things like that. But because I couldn't study or I didn't get a scholarship for medicine to be an MD, I ended up settling for biomedical engineering. It seemed like a very, sort of up and coming and interesting field. And so I came to Iowa, enrolled in a biomedical engineering program. I learned a lot, but I ended up thinking that I was doing health in the most expensive way for a small number of people. And I kind of wanted to do health for more people, and that was less expensive. And so that was sort of the public health end of the spectrum, from a very high cost, sort of care or equipment oriented health provision to more of a community oriented and prevention approach.
Right. And I know that when we compare health systems, that sort of cost benefit analysis always, factors into the discussion. Do we spend a lot of money to take care of a few people, or do we spend a lot of money to take care of lots of people, or less money, actually, in some cases, less money to take care of lots of people? And, I'm sure that trade-off is something that you deal with in your current position.
Oh, yeah, absolutely. So countries like Mozambique, have very, very poor economies. They don't have enough money that they can invest in appropriate health care facilities and systems in general, and so that's a real struggle. For example, Mozambique has one of the lowest ratios of population to healthcare providers in the world. And people sometimes don't believe that, and they say, oh no, Malawi has less, but among the countries in the region here, Mozambique has one of the lowest ratios. And not only that, but the folks who provide care in Mozambique, for the most part, don't necessarily have even a high school degree. They finish half of the high school program, and then they enroll into a program to be a medical technician of several different kinds. Mozambique is also a young country that gained independence very late in 1978, and then immediately went into a civil war and ended up destroying a lot of its infrastructure, including health facilities. So when I first came here in 2000, many of the facilities did not have water or electricity, or in some cases a roof, and they obviously were not enough for the population because the healthcare system hadn't grown since the independence days. Right.
And so, I guess one of my questions would be, what attracted you to Mozambique, especially under those circumstances? Was it because of the challenge? Or was it because of the need? Why go to Mozambique? Because obviously, someone with your background and expertise would have a lot of choices, I would think.
Yeah, well, I had spent 7 years working at headquarters in Atlanta, and also I guess I felt that I wasn't as effective, that I couldn't make as much a difference, sitting in Atlanta, making recommendations for public health programs, which are, absolutely necessary and extremely important, as we can see during the COVID pandemic firsthand. But I always felt like I wanted to be closer to doing something in the field where I could see an impact on the populations. And so I had some experience in Angola because I had been there for another short-term job with CDC. They at that time there weren't many people who spoke Portuguese, and because I was a native Spanish speaker, then they said, "Oh, he can speak Portuguese. Let's send him to Mozambique." And I ended up in Mozambique. And Mozambique is was a lovely country back then. In 2000, nobody knew about Mozambique. And it was a very sort of nice place. People were friendly and so forth. So when I came to visit, I said, "Yeah, this feels like I could do something here."
All right, very good. And I'm sure that the people you serve are very glad that you decided to stay. In fact, I think this is your second tour of duty, as it were, in Mozambique. So I want to ask you a little bit about the CDC because obviously during the pandemic here, the CDC got a lot of attention, but I'm not sure that the American public really knows that the CDC has offices abroad, that it has this international mission as well. Could you tell us about the CDC's presence globally and what it does?
Sure. So the CDC is primarily a domestic agency of our government. So we don't necessarily have a mandate to work overseas. But the CDC has for many years had several different research stations in Kenya, in Botswana, in South Africa, in Thailand, in China. And those stations used to focus on a particular disease or a particular group of diseases, and it was primarily around research. And then during the late 90s, I guess, when the pandemic of HIV was really beginning to grow, and particularly in Africa, the CDC decided to try to convince our government and Congress that something needed to be done to prevent a major loss of lives around the globe, which in part happened. But then at that point, the CDC decided to open offices, particularly in sub-Saharan Africa, in many of the countries in that region. And that's how we ended up here in Mozambique. So when I came to Mozambique, there was no CDC presence. And I essentially had to teach the people from the U.S. Embassy here. We work as part of the U.S. Embassy. We're one of the government agencies. And I needed to sort of teach them what we were supposed to do here, and that was not part of the Department of State's sort of vision for many of the people who work there.
Right. So you probably work pretty closely now with the U.S. mission in Mozambique.
Yes.
Right.
Yes.
Right. No, that's fascinating. Let's go back to Iowa for a couple of minutes, and especially the Department of Preventive Medicine, because I think at the time you were here, there was no College of Public Health, right? Or the College of Public Health was established during kind of the tail end of your experience here. So tell us what sort of that whole enterprise was like, or that academic unit was like, because now we have a wonderful College of Public Health, a beautiful building. College of Public Health started an undergraduate program about 4 or 5 years ago and has been successful in many, many different ways, and has become ever more important on campus, especially during the pandemic. But things have evolved very quickly, since the time you were here. But tell us what it was like,
Sure.
At that time.
Well, it was obviously very small. It was a program that in many ways it still exists, similar programs in other universities around the US, that was to essentially teach folks in medical schools or clinicians to do epidemiology and to analyze data with either research purposes or public health broader purposes. So it was, I think, I had probably about, 7 or 8 classmates in my group. I used to work in Oakdale campus, had a part of the hygienic laboratory. I had a little lab there where I did some research on pesticide toxicity. that's how I first came into the program. I had come back to the States after having to go to Venezuela to try and sort of repay my scholarship by working there for some time, and did not find a job. Then I came back to Iowa, which was a place I knew and liked, and enrolled in environmental engineering. And then I got to work on environmental, toxins and pesticides with a professor at the time, Bert Cross. And then I got more interested in public health and epidemiology and so forth.
Right, and it's such a relevant field, even now, especially toxicity, pesticides, how that affects agriculture, drinking water, the environment in general. The College of Public Health is doing a lot of work still in that domain.
Yeah. In fact, it's not only in the United States or in the developed world. It is a significant problem, and there is a lot of work that goes on that that happens around those topics. But in developing countries like in Mozambique, it's not so much so. But we know it still is a big problem. It's just that we don't really know much about it. And I can tell you a little bit of an anecdote about 6 years ago. There was an outbreak, a poisoning outbreak in one little town in the north part of Mozambique. And it was something like we've never seen before, probably, even around the world. 170 people died in 3 days. And so we went there with the Ministry of Health to try and investigate what had happened. And these people had all been drinking beer that it's a locally made beer that they brew in a large vat, and then they sell during particular celebrations. In this case, it was a funeral. And these 170 people died so quickly. So we went there with a lot of people from the ministry and investigated, interviewed people, considered pesticides, considered plant toxins, considered all kinds of things, food poisoning. And the only thing that came up was the drink. That was really what they all had in common. But then we couldn't figure out the drink. And this turned into a really interesting story, because there was sort of a little bit of witchcraft involved in it, and sort of beliefs about what people put in this drink. And they have some secrets about how they make this drink, and competition between different groups. At the end of the day, we found out that it was caused by a toxin from a bacterium that grows in the soil that had essentially contaminated the batch, and then because of the way that they make it and process it, it concentrated it, and it became really, really toxic. And the only reason we found that out is because we were able to send some samples to the FDA, and they did a host of chemical analysis, and they found out what the toxin was.
That's fascinating, and so my guess is that you've probably followed up with that village, and have kind of monitored things to maybe I guess the question is, what kind of information campaign do you start after a discovery like that?
There was a fair amount of education done at the time when we were doing the investigation, trying to first of all get stop people to from drinking any of these local beverages, because we wanted to make sure nothing was happening while we were investigating. But it's a common beverage that's made in the country, and so the lesson we took is we don't have a surveillance system. We don't have a way of knowing if this was an extreme event of something that happens regularly. Say 3 or 4 people die in a particular place because of this. And nobody really makes a story out of it or pays much attention, because we don't see it, right? It's just local. But this probably happens quite often, and other things like this probably happen a lot that we don't really have information about, and that's why surveillance systems and looking at public health and population health with a systematic way of doing it and using the appropriate tools is essentially very important, and that's what we do here. We support the government in trying to develop those systems. Right.
And so my guess is that a lot of your work involves learning on the job, sort of adapting, adjusting according to the circumstances that you see on the ground. And so that kind of leads me to my next question, which is, how has your research evolved over time? Especially say from an interdisciplinary perspective. What other sort of approaches, what other academic fields have you tried to incorporate into your research, especially when it comes to applied health in the public domain?
Right. So that's an excellent question. So my original training was in environmental and occupational health. That's where I started at CDC. And then there I did a number of different things, lead poisoning prevention, and then radiation protection, and so forth. But in terms of, and then I ended up first in migration, health of migrant populations, and then in HIV and infectious diseases. But particularly working in a developing country, anthropology is essential. So understanding what the local cultures are, how do they interpret things? What do they think about disease and health? How do you explain, some of these things in their own terms, particularly in a place like Mozambique, where the literacy rates are very low. So you have to come up with, ways to explain things to the population that are very simple and on their own terms and in their own language and so forth. There's about 20 different languages, major languages here in Mozambique. So anthropology is one of them. Another one is geography as well. I was actually remembering when I was thinking about what I would say here. Some of the people that were, part of my the reason I began to do this kind of thing at Iowa, there were several professors at the time. Jerry Rushton is one of them, and he's a geographer. And he was the first person that I really sort of learned a little bit of geographic information systems from. And that's a very key, in my opinion, tool to use for public health. Then there was Paul Greeno, who was a historian, and he was a very enthusiastic person, and he was a real strong force around creating this little group that catapulted me into global health, which was the Center for International Rural Environmental Health, CIRE. This was part of the beginnings of the public health school, I guess, right, in some ways. And then, in addition to that, I can't neglect to mention my thesis advisor, who was Lar Fortes. He was an occupational health physician, and he essentially held my hand through all of the vicissitudes of trying to get data in Costa Rica and making a successful dissertation out of it. And then finally, Dr. James Merchant, who was at the time the director of the program and then became the first dean of the public health school. And between him and Lar Fortes, they're the ones that actually enticed me and convinced me to apply to the CDC Epidemic Intelligence Service program. And that was sort of the beginning of my career.
Right. No, that's wonderful. I know that Dr. Fortes and Dr. Merchant are kind of luminaries here at the University of Iowa. I was wondering if you could talk a little bit more about them and just what it was like to work with them on an interpersonal level. You've already shared some of the lessons that you've learned from them, but maybe there are some others, that could illustrate, how you've carried your Iowa experience and your Iowa education with you and how you've applied it in your present work.
Yeah. So Dr. Merchant was, a very already prominent researcher in respiratory public health and pulmonary health and so forth, and so he was involved in sort of trying to really shape how people approached respiratory health from a public health perspective. He was very serious, but at the same time, he was very approachable, and he saw a real opportunity in trying to open up the possibility for people who were interested in international health And he pushed a lot, the idea of coming up with some grants and being able to begin this program in global health. And then Lar Fortes was, really a friend. He was much younger, and he was, he was the one who really took care of me on a day-to-day basis. And he accompanied me to Costa Rica to help collect data there. And we really laughed about it because I was also fairly young, and we ended up going to a banana plantation. We were going to study pesticide poisoning in the banana plantation, and the stories of banana plantation life were a little bit horrific, with people with machetes having fights and chopping each other off. And so I was going like, oh my God, I'm going to be left alone in this place, and I have to live in the banana plantation and collect my data. I'm not really sure I could do that. And Lara was the one who really pushed me to be brave enough to do that. And so I'm grateful to all of those people for their teachings and their support and helping shape my mind as a young professional.
Right, and no doubt you apply those approaches and those lessons to the people that you mentor now.
True. So that's indeed a lot of what we do currently. We really support several different institutions: the Ministry of Health, the National Institute of Health. We have as part of our programs here what's called the Field Epidemiology Training Program, and that's a program that trains field epidemiologists, and laboratorians to do outbreak investigations. And they actually were very instrumental in the response of COVID here in Mozambique. And that program, the Field Epidemiology Training Program, is modeled after a program at CDC in Atlanta that trains epidemiologists, that work at CDC. So Dr. Merchant had done that program, Lar Fortes had done that program, and I did that program as well. And that's it's sort of a keystone, training program for epidemiology. So so we do, all the people that work in my office, a lot of what they do is help and support and mentor Mozambican students that are also on their way to become an epidemiologist. Yeah.
Right. Wonderful, wonderful. So that's kind of paying it forward, as it were. So you mentioned COVID, and I'd like to obviously devote some time to the current pandemic that we're in, and unfortunately, it's still with us. Could you briefly describe the COVID situation in Mozambique? And then I'd like to take things more to a global level in terms of what you think has worked and what hasn't in our fight against the virus. But with Mozambique first, what is the situation on the ground where you are?
So in Mozambique in particular, the pandemic has been relatively mild compared to the rest of the world. But that's actually true of most of Africa. So most African countries have experienced a much milder impact of the pandemic, with the exception potentially of South Africa and some of the northern African countries, like in Middle East. And if you look at Southern Africa, South Africa experienced really, severe, significant numbers of cases, a number of deaths, but still, perhaps an order of magnitude smaller than many other countries in the West. And then Mozambique and all the countries around it experienced a pandemic that was, again, another order of magnitude smaller than South Africa. And, in the beginning, we had no idea what to expect. So when the pandemic began and we were sort of bracing ourselves for the worst, there was all this modeling going on, and we were doing some of that modeling with the institutions that we work with here. And the models were pointing to like 100,000 people dead, and so we were like, not sure what we're going to do if that is the case. We were particularly concerned because, HIV infected people, particularly HIV infected people who are not on antiretroviral treatment, who have a significantly compromised immune system. We thought that they were going to be much worsely affected. But that didn't seem to be the case. why, a lot of people ask, and asked me as well. And the only thing that we have so far is just theories. And there hasn't been really enough research. We haven't had a breather to sort of like do like the research. The research has focused on other things. But many people's opinions is less population density. Well, primarily the first factor is age of the population. Mozambique in particular, 60% of the population are below 18. So very young. I think it's something like 2% are over 65. So, you have a lot less susceptible people. In addition to that, because the life expectancy is shorter, then you also have a lot of less people with chronic diseases. So people tend to die younger, particularly in the rural areas, and in the urban areas, maybe a little older, and they're the ones who really have more chronic disease. And then lastly is population density. Even in the cities in Mozambique, the population density is much, much lower than even in South Africa and some of the other neighboring countries. So I think that has significantly affected the way the pandemic worked here.
Right. And have you seen, it sounds to me that you've seen the same phenomenon in other countries in the region, that Mozambique is not a unique case. So that countries either with younger populations, a smaller population of older people who might be more vulnerable, and then obviously population density factors into that, or lack of population density. That seems to be one, it's not really a formula, but it's at least a set of circumstances that could explain lower infection rates than in other parts of the world.
Yeah. And another thing that, it has occurred to me, but we haven't really done any research on it, is that, because Mozambique is a relatively poor country, particularly in the rural areas, and even in the urban areas, even peri-urban areas, people spend most of their time outside. They're not in an enclosed space, they're outside. Mask, that we can get a little more into the response and prevention and so forth, but at least in the beginning, the first 2 waves, the prevention measures were not really very well respected. It's really difficult to enforce those. Right.
Well, that's an occurrence that we've seen all over the world, and so that kind of leads to the second part of my question is, what do you think has worked in the global response to COVID, and then what hasn't?
Well, that's a really, really tough question. I kind of, go from one end to the other. I think prevention measures work. If you wear a mask, probably wearing a mask is one of the most significant prevention things that you can do, given what we know now. Not being in an enclosed space, being apart from other people, having ventilation, all of those things play a significant role. But if you look at the epidemic curves of the waves around the world, the entire world, and even if you look at just Africa, they're pretty much very similar. So even though many countries have done wildly different things, we have experienced more or less the same things. Maybe at slightly different times, but to me, what it says is, a lot of the force driving the pandemic is the virus' own characteristics and its transmissibility and how it transmits. And so what we have done has some impact, but little. And the only thing that really can have a much bigger impact is vaccination. And I think that's what a lot of effort we're putting, not only in the rest of the world, but also here in Mozambique.
Right. And if I'm not mistaken, I think President Biden convened either a commission or a conference not too long ago, it might have even been this week, to at least think about a global vaccination program. And I know that probably there aren't a lot of details, but it does sort of seem like that would really be the only way to effectively combat the virus. I'm wondering if you at CDC Mozambique, if you're working with partners either in Africa or other parts of the world on a global vaccine strategy, have you contributed to that, or has your opinion been solicited?
No, not really. I think South Africa is playing a more significant role. I think Mozambique, again, by virtue of being a poor country, we have really focused on what we can do to mitigate in the country. Mm-hmm. The Africa CDC, with whom we have contact, and they have contact not only with us, but also with all the countries of the African Union independently, they have done a lot in all different aspects of the epidemic. From sort of putting out guidance for testing, for genotyping of the strains, for prevention, for containment, doing case identification and contact tracing, to educational materials that are adapted to the cultural context, and then now vaccination, and also how to approach vaccination. To be able to educate people and to really avoid having people not wanting to get vaccinated because of conspiracy theories or whatever beliefs they have. So South Africa more recently has been discussed as a potential place where there could be some capacity put together to manufacture mRNA vaccines, mm-hmm. For the region, and that might really be the thing that really needs to happen in Africa to make sure that we get enough vaccines, because even the vaccination rates are way lower in mm-hmm. Africa. Mozambique right now is about 10% of their eligible population. And it's because we don't have enough vaccines. It's not because people don't want to get vaccinated. It's because we don't have enough. So part of what we have been doing is really trying to lobby for more vaccines to come to Mozambique. And that's also a complex process, because everybody wants vaccines, right? Everybody has their needs, and then there aren't enough for everybody, and you're trying to advocate for your country, but it depends also on what the capacity is of the country to administer vaccines, right? So they're not going to give you a lot of vaccines if you don't have the infrastructure and the manpower, the workforce to deliver the vaccines. So it all becomes sort of a very sort of balancing act.
Right, and absent a coordinated global strategy, it makes that sort of individual lobbying that much more difficult.
Exactly. Yes.
Right. No, and I think that's one of the sad consequences of this particular pandemic. I'm wondering, I know that this virus has been unpredictable. I guess I would ask you, since you're an epidemiologist, what has surprised you the most about COVID? Because this December will mark the start of our third year with COVID, which is kind of a sobering thought, but it is true. But you've obviously studied diseases, viruses, pandemics. What is different or unique about COVID in your estimation?
Yeah, well, I think that question probably would be more applicable to a virologist or somebody who can tell you what might be more innovative about the coronaviruses. But I think in general, the thing that surprised me the most, I guess I could say, is we had been talking about this for decades. I remember when I first got to CDC. A lot of the end of the world scenario involved having a pandemic with a respiratory disease or a significantly dangerous virus or disease that could be transmitted via airborne, right? Now, luckily, this is not airborne per se, right? So you don't get the disease because there are viral particles floating around in the air. You get it because droplets, from your respiratory system, when you cough or you sneeze or whatever, there are droplets that are transporting the virus. It's not really a truly airborne transmission, but it's more of a droplet transmission. And so that put a significant damper on it. If it had been completely airborne, then the transmission rates would have been much higher, like some of the other respiratory viruses that we have. But that was not the point. The point was that the most surprising thing is how we had been talking about this for so many years, and yet we were not prepared. Mm-hmm. We were not prepared from the perspective of stocks, of vaccines or other, masks and other, test kits. We didn't have tests, and we were also not prepared to really put together a very coordinated response, not even in our own country, right? But also across the world. Everybody was doing their own thing. So I think that probably is the single most important lesson that we all got out of this, which is really something needs to be done and we need to do better. And I think this is part of what President Biden was trying to do with his summit, which happened yesterday. And part of what they are trying to accomplish is to set targets for vaccination coverage in different countries around the world. And obviously that depends on vaccine availability, but hopefully that will come.
Right. And I'm just speculating here, but I kind of wonder if, on some level, it's definitely true that we weren't prepared, but I'm wondering if on some level we were complacent because, we saw outbreaks of H1N1, for example, of SARS, of MERS. And yes, they were harmful, but they did not rise to the level of a pandemic, at least not to the degree that we've seen with COVID. And so maybe we thought when COVID emerged, well, okay, it's going to be a lot like H1N1 or SARS back 20 years ago. Do you think that mentality kind of played into the response or the fact that we weren't as prepared as we should have been?
Yeah. In fact, we had a very interesting, we had a public health conference in Mozambique just a couple of weeks ago. And one of the invited speakers is a biologist who is also a journalist in Mozambique, one of their literary figures. He's written lots of books. His name is Mia Couto. And he writes a lot about the times of the war and social issues and cultural things. And he's a great novelist. And he was invited to speak at the conference. He's also part of this commission that advises the president on how to put together measures to respond to the pandemic. And he said his whole talk was about forgetting or actually remembering. I'm not sure which word he used. He made allusions to, he compared a lot to the Spanish flu pandemic and how, it's a generational thing, so we don't know how long it's going to take for us to forget this. And the people who perhaps didn't live it, like many of us now, we didn't live the Spanish flu, didn't really think much of it. And I think there is some truth to that. I think that we have a significant responsibility on our shoulders to really do something to prevent stuff like this from happening again. Because if we don't, we're likely to forget. And then the next 100-year, wave of this, something else is going to come and nobody's going to have to know how to deal with it.
It's great. That's a wonderful response. And let's certainly hope that we have learned our lesson this time around, because with the Spanish flu 1917, 1918, we'll say, well, that happened another lifetime ago or 3 lifetimes ago. So how is that at all relevant? And yet, here we are. A final question before we get to responses from the Q&A function. What other global health challenges lie ahead, in your opinion? And obviously besides COVID, and what do we need to do in general to improve global health outcomes?
Well, I would say one of the big ones is climate change. I think that, people think and talk about climate change in sort of abstract terms, right? But if you start to sort of look in more detail about the impact of climate change on a number of different things that have a direct influence on our lives and our quality of life is huge. So starting from coastal areas being flooded because rises of sea level, that's the one that most people are familiar with, and then also now the weather events, the weather extremes, this cyclones and things like that. 2 years ago, we had a cyclone here in Mozambique, Idai, that created a lake in one of the provinces in the center of the country that was, I can't even remember what the equivalent was, but it was overnight, over 2 days, all of a sudden we had a lake that was probably 100 kilometers across, and people who lived in that area all had to be evacuated, and then there was all the risk of, cholera and people, not having adequate water supplies and not having food. And then you get into outbreaks of cholera, outbreaks of measles, and And it's just a huge thing, and the extreme weather events are happening more and more often. So those are the most familiar things to people. But then there is, the impact on the ecosystems, right? So how many species are we losing, on a decade per decade basis because of climate change and other, human produced damage to the environment? But I think a lot of it is climate change. Loss of fish stocks and diversity, and then the impact of all of those changes into the existing ecosystems in the world. The loss of ice in the Antarctica and the Arctic. It's unbelievable, right? And then the last bit is, you have potentially a lot more opportunity for new infectious diseases that are either coming from areas that were not accessible to people before, or that are essentially, being generated by all these changes in the environment. Significant problems there.
Right, and the more that human and animal life converge, and that convergence is exacerbated by climate change, the more risk we incur that these new and highly unpredictable and more likely aggressive diseases will emerge. So no, those are wonderful answers. So let me read some of the questions that have been forwarded to you, Alfredo. So the first one is, currently, this is from Diane Rollman, professor in occupational health and environmental health. Currently, does pesticide research have is there an ongoing partnership in North Africa, and in particular Egypt?
So I'm not sure what the question is. I am not familiar with her research. I'm way far off from Egypt, right. But I would certainly like to know more about it.
Sure. Well, I guess, yeah. I mean, that might go to the question of, what pesticide research or what kind of pesticide research is ongoing in Mozambique, and how that might relate to other parts of Africa.
Yeah, not a whole lot. And I think that is a reflection of where development is right now in Mozambique. So agriculture in Mozambique is still very, very small scale. Only in the past 5 years or so, a few, large factory size, agricultural enterprises have surfaced, and those are the ones who tend to use a lot of pesticides or a lot of chemicals to make their production work. Most of the, I would say, so probably about 70% of the population in Mozambique is rural. And those people, for the most part, are subsistence farmers. So they have their own small plots, and everybody grows their food and eats their food. So they don't use a lot of pesticides because they don't have cash to buy either pesticides or fertilizers. So it's very old-fashioned, let's put it that way. But there are, growing industries in Mozambique. In particular, right now, the extraction industries. So coal in one of the provinces was a big development over the past 10 years. And now gas and oil and precious stones are being also found and began to exploit in the north of Mozambique. Those industries all have, sort of a potentially large, significant impact on, not only sort of the land use and the environment, but also contamination of water or soil or anything like that. Pesticide, hasn't really been much of an issue. In fact, when I was telling you about that poisoning outbreak we looked everywhere for potential pesticides that people could buy in the stores, and there wasn't really a whole lot. We couldn't find pesticides to be bought in a store. Now, that's not to say that they're not used. I know that there are some, small, but some banana plantation industry, some orange, and some sugarcane. I don't know. I'm not really familiar with really much research that's done in that area.
Right. And I sort of wonder, from kind of a cultural and historical perspective, if there aren't sort of indigenous methods that, combat problems with pests or, or that, help protect vegetation from certain insects or diseases that, that have been practiced for centuries. And that maybe could be brought to bear or used in a modern context.
Yeah, that's absolutely true. I don't really know, again, much about it, but I know that they do tend to mix their cultures quite a bit. So they plant corn and then plant tomatoes and they plant other green leafy vegetables that they use quite a bit for food. And so I think they do a certain amount of pest control that way.
Very good. Let me move to the next question, and that is, what is your advice for people who want to pursue a career in aid work in the field, yet also want to have a family life? How feasible is it to do both? I
have a family.
Right. It's a question we all deal with, I think, in one form or another. Yeah.
It depends on a couple of things. Your stage in life. I'm assuming if you're young, beginning at this, you go to the field and you take whatever experience you can get just to get some experience and to see what it's like and to see whether you really like it and you can do it and want to do it. As you get older, and so I'm thinking maybe sort of like Peace Corps or some work with NGOs that work very much at a community level, community-based organizations and so forth. And then I came to Mozambique. I was recently married when I came in 2000, and I adopted my kids here in Mozambique. So I have two well, they're not little anymore, but they're two Mozambicans, we call them. And they, so it is possible very much so to have a life. I know many people who work for NGOs here in Mozambique, and many of them have, spouses and children, partners, whatever. You can do it for sure. It depends on the situation and what kind of work you do. But if you do a lot of sort of emergency type of work where you have to go from place to place to place, that's a little bit more difficult to have a family. But if you do sort of more development and public health / development work, then you have a bit more stability.
Right, and you have your office and your lab, and so you're pretty much stable. I mean, you probably do some traveling, but you're place focused, and that has to help, right? Yeah. And so, kind of along those lines, we have a question where the colleague asks, for students who are interested in global health careers abroad, what sort of skills should we focus on developing right now while we're still completing our degree? And are there certain skills in your field that are particularly in demand?
Absolutely. So if you can crunch data and you can put it in intelligently displayed visuals, that is one of the most valuable skills, right? if you can learn how to manage data that comes from a variety of different sources, put it into one place, deal with all the quality of data issues, and then analyze it and display it. That's a really a good skill, and that includes geographic information systems, right? It also other skills that you have to work in overseas situations. We talked a little bit about anthropology and culture. You have to be able to kind of put yourself in the shoes of other people and sort of see the world and life how they see it, so that you can kind of understand and interpret what their needs are, and help them figure out what it is that you can do for them, and help them that way. So cultural proficiency, language skills, data analysis, and data visualization. Another one that I'm very sort of interested in is systems, right? So you can apply engineering system type of analysis and modeling and tools to understand how to provide healthcare and public health programming to either different populations or different geographies or so forth. So that's another good one to have.
Right. So it sounds like a good mix between the quantitative and the qualitative in terms of public health careers. Next question is in regard to industries. Do the aluminum, petroleum, textiles, and cement industries also contribute substantially to air quality issues?
This question is from my friend Bill Field, who was my classmate at Iowa, and I'm really happy to see that. And absolutely. Those are exactly the bigger industries at the moment. So we have a big aluminum smelter in the city, and we do wonder. Maputo is on the coast, and so there is it's very windy, but there's also a lot of population that lives on the inside where it's a little bit less windy, and actually the wind carries air pollution to those areas. So that's a significant issue there. There's also a huge cement factory that the Chinese opened up in an area that was not very populated, but it is so big that it actually has a significant impact on air quality in places that are easily 100 kilometers away. Textiles, that's a little bit less of an industry here, and then petroleum is still in the very early stages. So right now it's natural gas, but certainly the coal mines that are in the Tete province, those are also potentially a significant problem for air quality. Yeah. And hi, Bill.
Very good. And then our final question. Are you involved in any maternal health improvement or research initiatives?
Yes. So part of our the great majority of the funding that we receive is from the President's Emergency Plan for AIDS Relief. So we do, most of what we do is support the provision of prevention, care, and treatment for HIV. And that involves a number of different things. It involves working with key populations, which here are sex workers and men who have sex with men, or drug injecting users, or prison populations. Then we also do a number of prevention pieces of work, which include testing, obviously, testing of education, promotion of condom and other birth control methods. And also male circumcision, voluntary male circumcision. And then, one of the initial pushes for PEPFAR was to prevent the transmission of mother to child of HIV. And that has been one of the tough nuts to crack because of a lot of cultural issues. People here breastfeed their children for years, and so it's a little the only solution to that is to put the mother who is infected with HIV on antiretrovirals quickly, early, and at the same time, provide some prophylactic ARV treatment to the child so that there is, minimal risk of transmission. But because of that program, we do work a lot on maternal and child health in general. We also obviously look at children who are HIV infected and how to treat them. We work with orphan populations as well. So a lot of that.
Well, thank you, Alfredo. This has been a fascinating conversation. We very much appreciate not just your presence with us today and your time, but just the contribution that you're making in Mozambique and the world in general. Just devoting your life to public health is a very noble cause, and we want to support you in that. We're very proud of all the work you've done, and we're glad that the University of Iowa has played a part in all of your success.
Thank you so much. It was a pleasure, and I look forward to seeing you all in person sometime.
Yes, hopefully we'll have you here in Iowa City in the not too distant future. That would be great. All right.
Thank you so much.
Thank you, everyone. Okay, bye-bye.